All right, so we're going to talk about microangiopathic hemolytic anemia, or MAHA. It's a pretty complex topic. I'm going to try to distill it down into like the most important pieces. And in my opinion, I think this will be the only lecture you'll need for USMLE Step 1, Step 2, and heck, a lot of this can also transfer over to Step 3. It's also going to be really high yield for like clinical, like when should we suspect MAHA? I think it's a pretty complex topic, so I'm hopefully going to break it down into a way that is pretty easy to understand. So, some objectives. We're going to define MAHA. What are some red flags? What should be the initial workup? What's our schema? And then what are the major causes? So if you follow me on Instagram, this was the question I posed this morning. If you didn't, you can start fresh. So which of the following are the most specific to identifying MAHA? Platelet count, hemoglobin concentration, haptoglobin, or peripheral smear. So take a second, pause the screen if you need to. Consider it. So the answer here is actually going to be peripheral smear, and we'll get into more a little bit why. But like specific things are going to help rule out other diseases. Okay. So when I think about hemolytic anemia is a very broad complex, and I plan on doing a whole lecture on hemolytic anemia in itself at another point, probably pretty soon. MAHA is just one very small portion of hemolytic anemia. When I think about hemolytic anemia, we can break it down into inherited and acquired. And again, I'm going to break this down way more in its own lecture. But inherited, we can consider those are like hemoglobin problems, enzyme problems, and membrane problems, right? Examples of hemoglobin problems would be sickle cell, thalassemia, hemoglobin C, unstable hemoglobin. Enzyme problems would be things like G6PD deficiency, pyruvate kinase deficiency. Membrane problems would be like hereditary spherocytosis, elliptocytosis, stomatocytosis, and xerocytosis. When we think about like our acquired, we could have many different causes, right? There's going to be like autoimmune or like immunological, could be autoimmune, alloimmune type causes. We could have like PNH would be, I would consider like an autoimmune cause as well. When we consider other causes of inherited, or sorry, not inherited, acquired, we could think about like toxic causes. So like lead, arsenic, copper toxicity can all cause hemolytic anemia. Things like venom can also, like from the brown recluse spider, can cause hemolytic anemia. There are other causes like traumatic causes, so things like March hemoglobinuria, where a patient is running across a pavement and just the constant padding of their feet. We have small vessels in the feet that can cause shearing. Traumatic hemolytic anemia is where I would put MAHA kind of in, because we have things like hardware hemolytic anemia, where the patient has aortic stenosis, where they have a prosthetic valve where the red blood cell can shear across, and then our MAHAs themselves secondary to thrombotic microangiopathy, which is going to be the bulk of what we talk about today. And then there are infectious causes of hemolytic anemia. Some of the big ones that come to mind are like malaria, EHEC, Clostridium perfringens, babesiosis, brucellosis, Haemophilus, and babesiosis. So those are just some that come to mind. This is like the schema like I have in my head for whenever I'm thinking about hemolytic anemia. I think through all these different things and try to figure out what's going on. And we'll go through this in much more depth. And when I do my hemolytic anemia talk, we're talking about a very small portion, a very high yield, and very important not to miss portion of hemolytic anemia. So the other answers that we can like cross out, right? Platelet count, so many things can cause low platelets. That will be a whole lecture on its own. I'll do that at some point. Hemoglobin concentration, right? All those hemolytic anemias can cause low hemoglobin, so can a million other things. Low haptoglobin, so low haptoglobin occurs in all these hemolytic anemias, right? So I just named you several different kinds, not going to be very specific for MAHA. The peripheral smear showing schistocytes is going to be very specific for MAHA, right? There's only a few things, like the MAHAs are really the only thing when I see schistocytes greater than 1% that would cause that, right? So that's what I mean by specific. Okay. So what is MAHA? So first, these are our schistocytes, right? They might also be called, really like these ones are great examples. They might also be called helmet cells or triangle cells. MAHA is going to be non-immune hemolytic anemia due to mechanical red blood cell destruction in small vessels. So the red blood cells are going to get sheared across something, right? We're going to have to figure out what that something is. But when the red blood cells get sheared across, they're going to release a lot of their insides, right? Some of their insides include LDH, they include indirect bilirubin, right? So both of those are going to be elevated. They're also going to release their heme, right? And when heme runs free, we have a molecule called haptoglobin that binds up free heme, and they form like a polymer, right? They form a a complex, right? So the level of free haptoglobin goes down in my system, okay? Because it's binding up all this heme. So again, we're going to see low haptoglobin because it's binding up all the free heme, and we're going to see elevated LDH and indirect bilirubin because those are backbones. They're found in just a ton. They're found in like high amounts in my red blood cells. So when my red blood cells shear, they release the LDH, indirect bilirubin, and heme. The heme gets bound up by haptoglobin, so haptoglobin ends up being low. Free haptoglobin ends up being low. We're going to see those schistocytes, and then by definition, this is a Coombs negative anemia, right? Coombs negative, like Coombs positive, we're going to talk all about when we talk about autoimmune hemolytic anemia. So Coombs negative anemia means that there aren't antibodies attacking my red blood cell. The red blood cells are getting sheared for a different reason, right? In this case, it's usually due to mechanical stress, okay? Um, so a key clue is that it's often associated with thrombocytopenia, and we're going to talk about why coming up. So when should you suspect MAHA even before we draw labs, right? So like the patient presents to your clinic, they present to the ED, you see them on your IM rounds. Why would you suspect MAHA? Well, if my patient has mucocutaneous bleeding or petechiae, so sudden onset bruising, petechiae, or bleeding gums, that may signal severe thrombocytopenia. At very least, we should get a CBC and look at their platelet count. If they have altered mental status or neurological changes, right? Sometimes that is how some of these MAHAs present. And we're going to talk about a very specific one, TTP, that classically has confusion, headache, maybe seizures, even stroke-like symptoms, like neuropsych symptoms. So something to consider. If my patient has jaundice or scleral icterus, right, that's due to the rapid hemolysis of these red blood cells, the increased release of indirect bilirubin, which can build up and then cause jaundice, scleral icterus. The patient may also have dark urine from hemoglobinuria, right? If the hemoglobin gets released from these red blood cells, makes its way into the renal tubular system, can also cause dark urine. A key thing for hemoglobinuria and myoglobinuria that you might see in like rhabdomyolysis is if I do a dipstick, it will be positive for blood. Okay. That's because the dipstick can't tell the difference between actual blood, hemoglobin in my blood or in my urine, and myoglobin in my urine. Okay. So then what you're going to do is you're going to get an actual UA, and it's going to show you that there's like very little red blood cells. So a huge red flag is if you see the dipstick is positive for blood, but the UA has very few red blood cells, you should consider hemoglobinuria or myoglobinuria. Again, they'll get picked up as blood on the dipstick, but they won't have actual red blood cells on the UA because it's hemoglobin or myoglobin. It's not actual red blood cells. Um, we could also see signs of acute kidney injury. So maybe they're not peeing a lot. They have actual blood in their urine, right? Edema, hypertension. So that's seen in a lot of our different diseases we're going to talk about. So if you see anemia plus an AKI, we're going to think MAHA, okay, or at least push us down that path. Fever or systemic illnesses, a lot of these different MAHAs can present with like low-grade fevers, high fevers, neurological changes that we talked about. So when I see like fever, anemia, AKI, petechiae all together, we're thinking more MAHA, right? Pregnancy or postpartum state, we're going to talk about HELP syndrome, where I see a patient with a right upper quadrant pain, malaise, edema, and then our classic hemolytic anemia labs that we'll talk about in a second. We should consider HELP. So clues from the timeline and context, right? Bloody diarrhea 1 to 2 weeks earlier is classic for typical HUS. We're going to talk about uncontrolled hypertension plus acute symptoms might key you in on malignant hypertension. And then there are certain drugs. I didn't really talk about drug induced TMA because it's relatively more rare. But there are certain like chemotherapeutic drugs like gemcitabine and mitomycin C that can cause drug induced TMA. I wanted to put it in there just in case it ever shows up on the USMLE, but we're not going to talk about it much more after this. So I mentioned AKI. I want you to think about what are the 3 types of AKI and then how do we define them? So take a second and think about them. So with an AKI, right, there's 3 different causes. There's pre-renal, there's intrinsic, post-renal. When I think about pre-renal, I think about volume loss, hypotension, decreased forward flow of blood. When I have decreased forward flow of blood, right, it's going to activate my renin-angiotensin system. It's going to really cause damage to the kidney tubules or to the kidney itself if I don't have enough blood going for a long period of time. But the key difference here is usually the tubules can be okay, right? There's not an intrinsic damage to the kidney tubules. That is the hallmark of intrinsic AKI. So in pre-renal, it's just a lack of forward flow. The kidney tubules usually maintain their function for a long period of time without the blood flow, right? So in this case, the really big thing I'm going to look at is the fractional excretion of sodium, right? When there's a lack of forward flow, the renin-angiotensin system should be high, aldosterone should be high, and it should be causing the kidney tubules to hold on to sodium, right? So does Ang2. Um, if the tubules are okay, right, in pre-renal AKI, which they should be, it's just a lack of forward flow of blood, that fractional excretion of sodium will be less than 1%, okay? The urine osmolality is usually greater than 500. That's because antidiuretic hormone will be sky high, because remember back from my hyponatremia lecture, if our blood volume is low, that's a stimulus for ADH. The urine to plasma creatinine ratio will also be usually elevated. Again, a sign of pre-renal AKI. Um, our diuretics and CKD can confound the labs. And usually a key feature, if you ever read this in a question or you see a patient in real life, they usually have rapid improvement with the volume repletion. So really in these patients, the big thing that's happening is a volume loss, some sort of hypotension, decreased flow to the kidney. The tubules are okay. When I give them the fluid back, it kind of corrects everything. That's different from intrinsic AKI due to a poor, like these are going to be like the patient has a poor response to fluids. They have actual kidney parenchymal injury. Some of the massive things that can set this off are going to be like certain drugs like vancomycin, aminoglycosides, radioiodine contrast, rhabdomyolysis, so like the myoglobin, super elevated calcium, super elevated uric acid, can all cause acute tubular necrosis or like intrinsic AKI. In the urine, we might see granular casts or tubular casts. They might also be called muddy brown casts, right? That's because when we actually get necrosis of these tubular cells, they slough off, they bind up to TAM horsefall protein in the tubules, and they form these granular casts that we can see on urinalysis. The labs, usually we'll see a fractional excretion of sodium greater than 2%. It's for the exact opposite reason we saw a fractional excretion of sodium less than 1% in pre-renal. In this case, the tubules are actually going through necrosis. They can't form, like they can't really do a great job keeping sodium. So instead, the sodium should be reabsorbing here, especially if ATN, if this intrinsic AKI is caused by hypotension or a lack of forward flow, which it could be, okay? Sodium should be maintained. The kidney should be maintaining it. The fact that we're still excreting out a lot of sodium tells me my tubular system is actually damaged. Okay. There are some certain biomarkers. We're not going to talk about them, but I brought those on just in case. We could see proteinuria and hematuria if we actually have damage to like the glomerular basement membrane itself. In post-renal AKI, right, that's going to be due to some sort of obstruction. It's classically BPH in an older man or malignancy in stones. Diagnosis will do a renal ultrasound. We'll either see unilateral or bilateral hydronephrosis. You're classically going to see bilateral, right? Because if we think about it, where is like our BPH located? It's going to be located on the prostate, right, which is beyond the level of the bladder. So both ureters have already entered. They give the urine to the bladder. Bladder is going to empty through the urethra. If we have a constriction of the urethra, blood flows back into the bladder and then through both ureters and then into both kidneys, right? But if I had like a ureter stone on just one side, then we might have more of a unilateral hydronephrosis, right? So again, you might also see this. BUN to creatinine ratio is a poor marker for distinguishing between pre-renal or intrinsic and post-renal types. So you might have learned like pre-renal is classically like a BUN to creatinine ratio greater than 20. Intrinsic is usually like a BUN to creatinine ratio less than 20, maybe less than 15 to 1, right? It's not the best marker. Fractional excretion of sodium is going to be the best. So like again, in pre-renal, lack of forward flow, tubular system okay, fractional excretion of sodium less than 1%. In intrinsic, it could be due to hypotension as well, but the hypotension is really severe, or it could be due to intrinsic kidney damage via other mechanisms like certain drugs or iodine contrast, rhabdomyolysis, so like the myoglobin, calcium, uric acid. In this case, the tubular system is damaged, so the fractional excretion of sodium is greater than 2% because we can't reabsorb the sodium. And then post-renal, think about your BPH, think about malignancy, stones causing hydronephrosis. Okay, so that was just an aside. Really, the AKI, according to the KDIGO, AKI is defined by one of the following. We have an increase in serum creatinine greater than 0.3 within 48 hours. The serum creatinine has risen above 1.5 times the baseline within the last 7 days. or the urine output is less than 0.5 or greater than 6, we need one of the following to diagnose AKI. Okay, so when should we actually suspect MAHA? We should suspect MAHA in the following, right? If I see a patient with anemia, low platelets, high LDH, elevated reticulocyte count, schistocytes, and end organ damage, that should be MAHA until proven otherwise. Reticulocyte counts, remember I talked about this in my anemia lecture, but reticulocytes are immature red blood cells. They're produced from the bone marrow in times of low hemoglobin concentration, right? So this MAHA is happening out in the periphery, right? It's shearing the red blood cells across vessels for X, Y, or Z reason. It's happening outside the bone marrow. So our bone marrow should be totally fine. It should be able to mount an appropriate reticulocyte count. So your bone marrow is like, oh, shoot, the hemoglobin is really low. Let me pump out as many of these premature red blood cells, these reticulocytes, as possible to try to increase that hemoglobin. We think about hypoproliferative anemia when the reticulocyte count is either low or abnormally normal in a patient who has low hemoglobin or who has anemia, because in that case, the bone marrow is not responding properly. Remember, we talked about some causes of hypoproliferative normocytic anemia. Those would be things like a chronic inflammation, anemia of chronic disease, chronic kidney disease, hypothyroidism, and then some causes of bone marrow failure for X, Y, Z, drugs, aplastic anemia, things like that. So some red flags whenever we see like the anemia, low platelets, high LDH, elevated retic counts, schistocytes, end organ damage. If we see new neuro symptoms, if we see shock or sepsis, pregnancy with the right upper quadrant pain or severe hypertension, it might push us one way or the other. Again, I told you this, the greater than 1% schistocytes on peripheral smear is practically diagnostic. So again, anemia plus low platelets. Like honestly, like this, I had a really good attending who told me like, you ever see anemia plus low platelets, you should think about MAHA until proven otherwise. But then I get the rest of my labs, right? I see elevated LDH, elevated retic, elevated indirect bilirubin, schistocytes, end organ damage. Man, we're thinking MAHA until proven otherwise. If I see all this, or just anemia plus low platelets and neuro symptoms, I want you to think about TTP right off the bat. And we'll talk about why, because that's probably the most scary, along with DIC, and that'll kill the patient if we don't treat them. So we'll talk about why. So my MAHA schema, we have thrombotic microangiopathy and non-thrombotic microangiopathy. We're going to spend the majority of our time on the thrombotic. So this is basically, we're making a thrombus. That thrombus is then causing obstruction in the vessel, and the red blood cells are shearing across the thrombus, okay? Non-thrombotic microangiopathy occurs for another reason. We're only going to talk about one non-thrombotic microangiopathy because I think it's the most high yield of the non-thrombotics. The other ones could be a lecture on its own. I plan on talking about some of them at another point. But our examples of the TMAs are going to be TTP, HUS, DIC, HELP, and malignant hypertension. So let's get into it. We have vignette number 1. We have a 28-year-old female presents with confusion, petechiae, low-grade fever. The labs show a hemoglobin of 8.5. Platelets are 10,000, creatinine 1.2. The LDH is really high at 1,200, and the smear shows schistocytes. So take a second, think about what your most likely diagnosis is, pause it. So when I see those constellation of symptoms, I immediately think about TTP. Remember, anemia, low platelets, new neurological symptoms. I want to think about TTP before everything else. And we're going to talk about why. So some questions I want you to consider. This would be a good point. Pause your screen and consider these. So we're going to think about what's the pathophysiology of TTP? How do you monitor response to therapy? When is rituximab added? And what are the risks of delaying treatment? So the pathophysiology, it's caused by a severe ADAM TS13 deficiency. So remember, ADAM TS13 is what cleaves my von Willebrand factor multimers. So if I don't have ADAM's T13, this might be like acquired, or maybe we have autoantibodies against it. Then we're not going to have the thing that cleaves von Willebrand factor. Von Willebrand factor stays in these large multimers, and it just acts as like a kind of jumping off point to cause all these platelets to clump. Remember, von Willebrand factor sits in my endothelial space, and when it gets kind of released, when it gets exposed, it binds to GP1B on the platelets. The platelets then have these GP2B3A receptors that bind fibrinogen, and then on top of the fibrinogen binds more platelets, right? So when I have these super large von Willebrand factor multimers, it's just acting like more of a nidus to cause platelet activation, right? So we get these large platelet clumps, right? It's very similar, but different to DIC. So it's not quite a full-on consumptive coagulopathy. It is in the sense of platelets, right? So we're going to use all of my platelets because they get overactivated by the von Willebrand factor, and they form all these microthrombi, especially in the kidney, even more so in the small little vessels in my brain, and they're going to block off blood supply, right? So that's why these patients classically have neurological symptoms, right? So with regards to this, though, we're using up all my platelets, so then my platelet count plummets, right? And the platelets in these patients are classically like less than 30, even 20,000, right? So when I see anemia plus really freaking low platelets, I have to consider TTP, especially in like a woman of reproductive age. Those are my classic autoimmune patients. You know, anywhere between 20 to 50, I could even extend it out to like 6 years old. Those are like classic autoimmune patients. That doesn't mean only women of reproductive age get it, but it's like it would key me in even more. Um, so to monitor treatment response, we're gonna look at platelet counts, LDH, clinical resolution. For TTP, whenever you suspect TTP, we start plasmapheresis plex before we do any more like confirmation, right? Ultimately, we're going to want to get ADAM TS13 level. That takes a while to come back. If I have any suspicion of TTP, we start plex before any of those labs come back. Because if we don't start plex, plasmapheresis, I'm taking out the bad blood, giving them the good blood, the patient could die. Okay. So we usually start Plex, and we usually will start methylprednisone on top of it. And then rituximab can be used either upfront in acute immune TTP. If we have a refractory suboptimal response, rituximab can be added. It can be used preemptively if we already know the Adams TS13 is less than 10 to 20%, and it's associated with fewer relapses and better survival. So really, the right question on your board exam, if you get a question on TTP, you're in like step 2, step 3 land, we start Plex, no questions asked, okay? Maybe they give you a question where the Plex has already been started and ask you about next step. I would go to steroids next, and then on top of that, I would do rituximab. Um, I will tell you, everyone memorizes the FAT RN mnemonic. It's the same mnemonic you can see in HUS. So it's fever, anemia, thrombocytopenia, and then the RN would be renal and neurological. Classically, like data has shown that less than 7% of TTP have the full pentab. You'll usually probably see like a younger female who has the petechiae. Maybe they'll give you an anemia. Maybe they'll give you a low-grade fever, and maybe she has new confusion, right? That might be all they give you, and that might all be all you see in real life too. So we have to have a really strong clinical suspicion for TTP. Okay, less than 7% have that full pentab. And if you want to read more, here's the journal article. Um, I wanted to also include in this lecture like some new clinical updates or newer. There's this beautiful new drug called caplacizumab. It is a anti-von Willebrand factor antibody, and it can clinical trial, this Hercules trial, showed that it reduces time to platelet normalization and decreases relapse. So it could be considered in addition to Plex and steroids in hospitalized patients with TTP. So again, the pathophysiology, we have too large von Willebrand factor because we've lost ADAM TS13. So this caplacizumab makes sense, like pathophysiological wise. Let's give an autoantibody that stops the von Willebrand factor that's driving this pathophysiology in the first place. It's used a lot in Europe. It's very expensive in America. So it's not like formally in the guidelines yet, but it can be used. So I've got like some Plotkin's pearls that I want you to remember. So step 1, like if you're in step 1 land, Adams TS13 less than 10% confirms a diagnosis, but we're not going to wait, right? I want you to think about the FAT RM. They might not give it all to you, but again, if you see a patient with anemia, really, really low platelets, they have a fever, they have neurological symptoms, maybe they give you the renal symptoms or the elevated BU and the creatinine, the AKI, or the fractional excretion of sodium. Right now, we're thinking TTP, absolutely. Step 2 land, TTP is a medical emergency, like I said. We go to plasma exchange right away. I'm not waiting. Step 3, maybe they already told you in the vignette that we gave them plasma exchange. So what do I do if I'm on my USMLE step 3 exam and they tell me, hey, we already gave them Plex. Oh, shoot, that's all I knew. Now you know we give steroids, and then we can add rituximab. And maybe by the time some of us take step 3, caplacizumab might be in the guidelines now too, so we can consider that drug as well. Okay, that's TTP. So now we got vignette number 2. We've got a 5-year-old boy with pallor, decreased urination 1 week after bloody diarrhea. His labs show a hemoglobin of 7.9, platelets of 55,000, creatinine 3.1, and schistocytes. So take a second, think about the most likely diagnosis, pause your screen if you need to. So this is our classic hemolytic uremic syndrome. So I want you to think about, why don't we give antibiotics in typical HUS? What's the difference between typical and atypical HUS? What organ systems are most affected? So pause your screen. This will be a great time to think about these, and then we'll move forward. So typical HUS is classically caused by Shiga toxin releasing E. coli, or EHEC, enterohemorrhagic E. coli, also called 0157H7, right? You might see it a million different ways. It produces the Shiga-like toxin. It's also called varotoxin. This is going to cause the endothelial cell damage, the overactivation of platelets, my platelet clumping, ultimately causing a microthrombi that the red blood cells are going to shear across. We've overactivated all my platelets, so the platelet level ends up dropping. We get thrombocytopenia. I will tell you the big difference. So both, like I told you, TTP and HUS can both have that fat RN mnemonic. Again, I showed you TTP, less than 7% have the full thing. HUS, there's not really like great data on like who presents with what types of symptoms. I will tell you, they know from the literature that TTP classically is more linked to the neurological manifestations, whereas HUS is more linked to the kidney manifestations, right? It's not always like black and white like that, but TTP more so the neurological symptoms, HUS more likely the AKI, right? But you can have both. So the EHEC is classically preceded by bloody diarrhea, right? So the bloody diarrhea might key us in onto the clinical presentation. We usually avoid antibiotics because they increase the Shiga toxin release and the HUS risk. So classically, the vignette, so a lot of patients will get this EHEC. They're eating undercooked beef and they'll be totally fine, right? They might have like a somewhat of a non-bloody diarrhea, and then they'll recover. The problem usually happens once we give the patient antibiotic. You know, they go to the emergency room or they go to their physician and their physician prescribes them antibiotics. The antibiotics further increase the Shiga toxin release and are going to further risk us for having HUS. So that's like the classical vignette. You have a patient who went to like a barbecue, they had some diarrhea, now they got this prescribed this antibiotic, now it's bloody, now they present with anemia, thrombocytopenia, and an AKI, classic HUS, right? We also avoid loperamide, right? So that's a going to slow down transit in the gut. So that's like a opioid that acts in the gut. And what opioids do, they cause constipation, right? So it's a great drug for diarrhea. Not in this case, though, because it's going to keep the bacteria inside the colon and allow for more of this Shiga-like toxin to be released. Atypical HUS is not usually associated with an infection. It's caused by complement dysregulation. So there's some sort of genetic mutation or autoantibodies. You're usually going to have you are going to have overactivation of C3 and C4 in your complement system. So one way we can test for it is we get complement levels, right? You'll see low C3 or C4. These patients are at a higher risk for recurrence and progression to ESRD, because this is a underlying like genetic or autoimmune problem. Typical HUS is a kind of like a one-time, man, you got crappy luck, you got this EHEC, the Shiga-like toxin overproduced, we cause endothelial cell damage, platelets get overactivated, we cause a microthrombi, we sheared across, right? Once you're taken care of, right, we treat it supportively. Once you're taken care of with typical HUS, you know, you would have to eat the infected meat again to potentially get it again. When you have atypical HUS, that is a underlying genetic autoimmune, you're pretty much always at risk, right? Especially if you have underlying stress to the system. Organ involvements, like I said, kidneys are most effective. Acute kidney injury is the key feature. So we classically see anemia, thrombocytopenia, AKI. Your platelets usually aren't as low as they are in TTP. TTP, remember, are like less than 30, 20,000. They're going to be low in HUS, but usually not as low. And again, we can injure a lot of different organ systems. If you want to read more on HUS, here's the DOI from the New England Journal of Medicine article that I think is really good. Just take a screenshot, throw that into Google. A newish clinical update on for atypical HUS, we have this drug called eculizumab. It's a C5 inhibitor. So it improves, it's actually showed to improve renal function and decrease dialysis dependent. There's a lot of data on it. I found a great New England Journal of Medicine article if you want to read further on it. So again, it's like a C5 inhibitor. It's also used in PNH. PNH will be a story for another day. Otherwise, this lecture is going to take too long. But it's a great drug if they ask you how to treat atypical HUS, or they'll give you a patient with anemia, thrombocytopenia, AKI. They won't have this history of bloody diarrhea. They'll tell you something about like no Shiga-like toxin was found or something like that. So they'll like rule it out for you. So you're like, this must be atypical HUS, right? I could give this drug eculizumab, which is a C5 inhibitor, which will shut down the complement system that's causing the endovascular damage and the thrombotic microangiopathy in the first place. So my pearls for step 1, I want you to think about HUS is by this Shiga toxin producing E. coli 015787. For step 2, I want you to think about treating with supportive care only. No antibiotics, no anti-motility agents. For step 3, we're going to monitor for AKI and electrolyte disturbances. We may need to progress to dialysis if it's bad. For atypical HUS, I want you to consider in MAHA with renal failure, but there's no history of diarrhea, right? So that's step 1 land. For step 2 land, they might ask you more about the mechanism. They could ask that in step 1 too, but it's caused by the complement dysregulation. And step 3, they might ask you about this unique treatment, eculizumab, a complement inhibitor. Okay. So vignette number 3, we have a 65-year-old male with septic shock. He's bleeding from his IV sites. His labs show a hemoglobin of 9.2, platelets 30,000. His PT's elevated, fibrinogen's low at 80. The D-dimer is very high and the schistocytes are present. So what's the most likely diagnosis here? So in this case, it's DIC. I did a smaller lecture on DIC versus liver disease a couple days ago. We'll talk about it a little bit more. So pause your screen, consider these questions. What's the pathophysiology? How do I differentiate DIC from TTP? When do we give platelets or cryoprecipitate? And what conditions commonly trigger DIC? So pause, think about these, and I'll move on. So the pathophysiology, we get systemic activation of our coagulation factors and widespread microthrombi. So there's some sort of underlying stressor. Our whole entire platelets and our coagulation factors get overactivated. We cause clot, 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 clot until all of my platelets and clotting factors get used up, and then we bleed, 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 bleed. So usually these patients present with a lot of bleeding from random sites because by the time they get to the hospital, they've already had this consumptive coagulopathy. So that bleeding, right, and cutting off blood supply to certain systems are going to cause massive organ dysfunction. It's usually triggered by tissue factor exposure from underlying sepsis, trauma, malignancy, obstetric complications. The obstetric complication is classically amniotic fluid embolism. So look for a patient who just gave birth. Some sort of crossing over of the amniotic fluid into maternal system triggers a massive immune response. The patient goes into DIC. We'll talk about the labs in a second, but we talked about them in the liver disease versus DIC lecture 2. So management, we're going to treat the underlying cause. Step 1, right? If the platelet transfusion, if they're actively bleeding or the platelets are less than 50,000 in high-risk situations, and then we can give cryoprecipitate if the fibrinogen is less than 150. I've seen some sources that say 100 to probably like avoid any kind of controversy. They might give you like on an exam like a platelet or fibrinogen of like 80, right? So it's less than both. I think newer sources are saying 150. Older sources might have said more towards 100. Remember, cryoprecipitate is going to have factors 8, 13, von Willebrand factor, fibrinogen, and fibronectin in it. So to tell the difference between DIC and TTP, really I highlighted the two big ones, but we're going to see low platelets in both. We're going to see elevated D-dimer probably in both. Maybe TTP might have normal, but really the big difference is in DIC, it's a whole consumptive coagulopathy. So the PT and the PTT are elevated. But remember, in TTP, we were just talking about platelets, right? The coagulation factors have nothing to do with TTP. It's an overactivation of von Willebrand factor because we lose ADAM-TS13 that causes an overactivation of platelets. Nothing to do with the coagulation factors. So the PT-PTT can help me in there. And then fibrinogen is classically low in DIC, but normal in TTP. Again, because fibrinogen gets converted into fibrin via thrombin, right? Thrombin cuts fibrinogen into fibrin. Remember, it's not the coagulation factors aren't really involved in TTP, so fibrinogen should be totally normal. In DIC, it's really low because we're making clot, 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 clot. So we're using up all my fibrinogen, right? And then if you want to just connect this to the liver disease lecture I talked about, remember, severe liver disease can present very similar to DIC, right? The way we tell them apart is in DIC, the fibrinogen's low. In liver disease, it's usually normal or even elevated because liver disease, we can lose all of our clotting factors because the vast majority of them are made in the liver. But remember, factor VIII is a weird one. It's made outside of the liver. So you could have a patient with very severe liver disease showing up just like a presentation like DIC. They could have an elevated PT and PTT. They could have a low fibrinogen because fibrinogen is made in the liver, but their factor VIII is going to be normal or high because it's made outside of the liver. In DIC, it's low. Go watch my liver versus DIC disease, and you can learn more about that. I go all into it. So my pearls, DIC is a consumptive coagulopathy, so high PT, PTT, low fibrinogen. For step 2 land, MAHA here is secondary to fibrin shearing the red blood cells. And step 3 land, treat the underlying cause, transfuse platelets or fibrinogen if there's bleeding, right? So platelets usually less than 50,000, cryoprecipitate usually less than 150 or 100, depending on the source. Okay, so vignette number 4. We have a 31-year-old female at 32 weeks pregnant. She's got right upper quadrant pain, malaise. Her blood pressure is 160 over 102. Her labs show a hemoglobin of 8.4, platelets of 75,000. AST and ALT are both elevated and schistocytes are seen. So think about which disease this is. Pause your screen. So this is going to be HELP, which stands for hemolysis, elevated liver enzymes, and then low platelets. So you can pause your screen here too and think about these questions I'm about to ask. What's the pathophysiology of HELP? How do we manage HELP if the patient's less than 34 weeks? What complications should you monitor for postpartum? And what are the indications for immediate delivery? So pause your screen and we'll consider them. So HELP is going to be triggered by abnormal placentation. So the placenta ends up in a spot that it's not supposed to be in. Your immune system recognizes that as irregular. It causes systemic endothelial cell dysfunction, and that leads to hemolysis, elevated liver enzymes due to hepatic ischemia, and some fibrin deposition. We get low platelets due to platelet consumption, and complement can even be activated, which worsens the microvascular injury. For management, so if the patient's less than 34 weeks, we want to stabilize the mom. Usually before 34 weeks, up to 34 weeks is indication to usually give corticosteroids. Like betamethasone is usually the go-to. For fetal lung maturity, we can give magnesium sulfite if we're concerned for seizure, like seizure prophylaxis, like if this patient has qualified for eclampsia, which again, it's going to be its own lecture I'll do at some point because that's too long to do in here. It's too not enough to give it not enough justice. We can give antihypertensives, right? So like the 4 antihypertensives that are usually safe in pregnancy are like nifedipine, hydralazine, labetalol, and alpha methodopa. And then we can consider 48-hour expectant management if both mom and fetus are stable, right? But indications for immediate delivery, if mom presents with HELP greater than or equal to 34 weeks, that's an indication. If the mom starts like deteriorating, right, uncontrolled hypertension, she goes into DIC, renal failure, or hepatic rupture, indications to deliver. And if mom has non-reassuring fetal status, all indications to deliver. So again, if less than 34 weeks, we're going to try to do everything we can to stabilize mom and the baby, or at least get the baby somewhat ready to have this preterm delivery. If we can't though, right, we're going to deliver, right? And if we're greater than 34 weeks, that's an indication to deliver. The mom is worsening and the baby's worsening, that's indications to deliver as well. So some postpartum complications to monitor. The mom can go into DIC. She can get a hepatic hematoma. She can have hepatic rupture, acute renal failure, pulmonary edema, amongst others. Some labs usually will improve around 48 hours postpartum, but we really are going to want to monitor these patients, right? Because really the thing that's going to cure the mom is delivering, right? Because it's an abnormal placentation that has kicked off this entire pathophys. So if we give birth, we remove the placenta, that takes care of the pathophysiology. So Plotkin's pearls for step 1, we're going to want to think about a pregnancy-specific cause of MAHA. Think about HELP, right? The classic step 1 question is they'll give you like the hemolytic anemia labs, and then they'll give you like low platelets and ask what else might you see, and they'll have one of the options will be like elevated AST and ALT, right? That's going to be your answer because they want you to think about HELP. For step 2, now we're putting the full clinical picture together, right? When I see hemolysis plus liver destruction plus thrombocytopenia in the 3rd trimester of pregnancy, they want me to pick HELP as the answer, right? For step 3, the definitive treatment is delivery, regardless of the gestational age, right? If they ask you, what is the definitive treatment for this patient's condition? We deliver, right? If we deliver, we remove the placenta that was in the wrong place to begin with, takes care of the whole pathophysiology. This again is why pathophysiology is so important. If I understand the pathophysiology, I can understand the proper diagnosis, I can understand the proper management. Never sleep on the pathophys. For vignette number 5, we got a 52-year-old male. He has new blurry vision and headache. His blood pressure is 230 over 140. His labs show a hemoglobin of 8, platelets of 100,000, creatinine of 1.8, and his smear shows schistocytes. What is the most likely diagnosis? So pause your screen and think about it. So this is going to be malignant hypertension causing microangiopathic hemolytic anemia. So I want you to pause your screen again and consider these options. Why does hypertension cause MAHA? What is the target blood pressure drop in the first 24 hours? And what other signs of end organ damage should we monitor? So pause, think about those. So the pathophysiology, when I have really severe blood pressure elevation, that itself is going to cause endothelial injury. That can also lead to fibrinoid necrosis, right? That's a classic step 1 question. When the blood pressure is super high and you're suspecting malignant hypertension, they would ask you, like, what would you see under the microscope, or like something along like the lines of what's the actual pathophysiology? It's fibrinoid necrosis. We're actually causing necrosis and endothelial cell damage to these vessels. This can lead to microvascular thrombosis because if I cause endothelial cell damage, it opens up von Willebrand factor to cause platelet clumping, right? And then we get this microvascular thrombosis. The red blood cells can shear across these microthrombi, and then we get thrombocytopenia for the exact same reasons I've discussed previously. Usually, like the pathophys can also involve an increase in von Willebrand factor and a decrease in ADAM-TS13. The reasons for it, they're not fully sure. It's just kind of been in the literature here and there. I would really worry about this portion. So again, severe blood pressure elevation causes endothelial cells damage. Fibrinoid necrosis that activates von Willebrand factor will activate platelet clumping, microthrombi occlusion. We get red blood cells shear across. We get our schistocytes and thrombocytopenia. To manage our blood pressure, we reduce the MAP by 20 to 25% in the first hour. Remember, MAP is 2/3 DBP plus 1/3 SBP. Go to my heart failure lecture, and I explained that whole process in that one. I also explained it, I think, in my Waterhouse-Fredrickson lecture too. So then we aim for a blood pressure of 160 over 100 to 110, right, over the next 6 hours. We want to avoid rapid drops because if we drop the blood pressure too fast, we're going to drop the blood flow that was going to really important organs like my kidney and my brain, so it can lead to AKI and stroke. We want to monitor for other end organ damage in these patients, so things like encephalopathy, seizures, visual change, and stroke, acute coronary syndrome, heart failure, arrhythmias, AKI, hematuria, proteinuria, papilledema, retinopathy, and then aortic dissection. All things I need to consider when I'm thinking about hypertensive emergency. So that's blood pressure either 180 over 120, right? So either or plus end organ damage, hypertensive emergency. Our workup should include fundoscopy to look at the eyes, a neuro exam, and an EKG to look for any arrhythmias or like left ventricular hypertrophy, things like that. We want to get a creatinine and a UA to see do we have kidney damage. We want to get a CBC, LDH, haemoglobin, and peripheral smear to look for MAHA, right? The whole point of this lecture. So my pearls in step 1, think about severe hypertension causing this vascular shear leading to MAHA if they ask you about the pathophysiology. For step 2, the blood control is key, like in our treatment. It needs to be lowered gradually. They're probably not going to ask you by which much, but they could give you different options, right? We want to do gradual blood pressure dropping. And then for step 3, we want to avoid overcorrection, right? So we could have watershed stroke. So remember, the watershed portion of my brain is where the MCA meets the ACA and where the MCA meets the PCA. So if we reduce blood flow, right, hypoperfusion, those portions of my brain are going to be underperfused, right? So if you ever get a USMLE question or in real life and you see a patient who has ischemic stroke or a lack of blood flow, hypoperfusion, to the portion where the MCA meets the ACA and where the MCA meets the PCA, you should think about, they'll ask you like, what was the underlying cause of this patient's symptoms or this presentation? It's hypoperfusion because those are the watershed portions of my brain. So another good article if you want to read about that. Almost done here. Vignette number 6. So we have a 45-year-old man presents with progressive fatigue, dyspnea on exertion. He has a systolic ejection murmur heard best at the right upper sternal border. The physical exam reveals conjunctival pallor and mild scleral icterus. Labs show a hemoglobin of 7.9, platelets 180,000, LDH markedly elevated, his haptoglobin is undetectable, and the total bilirubin is 3.2 and it's predominantly indirect. Peripheral smear shows numerous schistocytes. The Coombs test is negative. I want you to take a second and think, what is the most likely diagnosis? Pause your screen if you need to. So one thing that sticks out here is I'm leaning towards hemolytic anemia. The weird thing though is his platelets are totally normal, right? Remember, in all of my thrombotic microangiopathies, they've all been low, right? And in TTP, they were super duper low. So this is kind of weird, but the LDH is elevated, the haptoglobin's low, and the indirect bilirubin is high. So I'm like, yeah, this is probably hemolytic anemia, but something's going on here, right? We have this classic murmur that's a systolic murmur. It's an ejection murmur. It's sort of at the right upper sternal border. That's classic for aortic stenosis. So this is going to be MAHA secondary to aortic stenosis, right? I put a question mark here because I remember like teaching this to some of the M1s and they didn't even realize like this was a thing. So it should definitely be something on your radar. So pause your screen, consider these questions. So what is the pathophysiology of MAHA secondary to aortic stenosis? Our patient's 45 and he has aortic stenosis. Why, right? What are the indications for aortic valve replacement? And if our patient had a mechanical aortic valve, which type of anticoagulation should they be on? So pause your screen and consider. So the pathophysiology, when I have a really stenotic valve of my heart valve, or I have a mechanical valve that's also like relatively stenotic and it's a new type of material, right? That can lead to high shear stress. Okay, so the valve isn't moving as much, the diameter is closed, and my blood is just getting shot up through that aorta via the left ventricle, and it's just going to shear a lot of those red blood cells, right? So these red blood cells get fragmented, we get schistocytes, we get the elevated LDH, and we've got our classic MAHA presentation. We also, right, can get von Willebrand factor cleavage, okay? So this is something called Hyde's syndrome, where we end up cutting von Willebrand factor. So von Willebrand factor doesn't work as well anymore. And so in this case, right, what does von Willebrand factor do? I already told you at the beginning of this lecture, it's going to help clot. So in these patients, if we lose von Willebrand factor due to this severe stenosis or a mechanical valve, then we're not going to be able to clot as well, and the patient is predisposed to bleeding. It's classically in the GI tract, right? So you could see angiodysplasias in the GI tract. So something to consider. When we think about why does this younger adult have aortic stenosis, in patients less than 70 years old, you need to think about bicuspid aortic valve. So the aortic valve usually has 3 cusps. When it has 2, it makes it more stenotic-y. Okay, stenotic-y? Yeah. So it leads to premature calcification and degeneration, which then causes the stenotic valve, right? Classic. So this is like a really good step 1 question. You'll get a patient who's younger, like 50 years old, has this right upper sternal murmur. That's a systolic murmur at the right upper sternal border. It radiates to the aortas, right? And they'll ask you why, and you're going to pick bicuspid aortic valve, right? Premature calcification. So indications for aortic valve replacement, if they have symptomatic, right? So it's our classic syncope, angina, heart failure, dyspnea type picture. If they're asymptomatic, but you have severe aortic stenosis, in which the left ventricular ejection fraction is less than 50%, they're planning on undergoing some other cardiac surgery, or their Vmax, so the velocity max through the diameter is greater than 5. Those are all indications for aortic valve replacement. And then once we've replaced the valve, right, if we put in a mechanical valve, the patients need to be on a lifelong warfarin, a vitamin K antagonist. So our target INR is 2 to 3. It may vary by valve type or risk, but 2 to 3 is the classic. DOACs are contraindicated in mechanical valves. There's not enough data on them. So whenever you see a patient with a mechanical valve, as of right now, they're always put on warfarin. That's a classic question as well. So my pearls for you, in step 1 land, think about a systolic murmur heard best at the right upper sternal border that radiates to the carotid. That is our aortic stenosis. Look for the hemolytic anemia on top of it. For step 2 land, I want you to be able to recognize hemolytic anemia plus aortic stenosis and hemolytic anemia plus von Willebrand factor deficiency plus that aortic stenosis, right? So now we're adding in that Hyde syndrome. I think that's pretty low yield for step 1. Definitely could be tested on step 2. In a patient less than 70 with aortic stenosis, think about bicuspid valve. Step 3 land, the post-AVR, the patients are on lifelong warfarin. If the left ventricular fraction is less than 50%, they're symptomatic. They're going under another cardiac surgery, or they have this Vmax greater than 5. Those are all indications for surgery. If you want to read more, there's a DOI. You can copy and paste that in or take a screenshot. So to put it all together and finish this out, We have a 24-year-old female. She presents with confusion, fatigue, low-grade fever. Her eyes are slightly jaundiced, and she has petechiae on her lower extremities that are non-palpable. And this we'll get into a whole whenever I do my vasculitis talk. We'll talk about why this non-palpable matters. Too much for today. I'll tell you, your small vessel vasculitis are classically palpable purpura due to the actual inflammation of the vessels itself and then extravasation of blood. When I think about non-palpable purpura or petechiae, I think about actually bleeding into the skin, which points me more towards thrombocytopenia. I will go into this way more when I do my vasculitis talk. So we have all this. What is the most appropriate initial workup to confirm suspected MAHA? So we're thinking about MAHA here, right? If we remember back to the first couple slides, I told you what the workup should be. So pause your screen, see if you can rattle them off. So in this patient, right, if we're suspecting MAHA, we want to get a CBC to assess for anemia and thrombocytopenia. We want to get a peripheral smear to identify schistocytes. Remember, that's the most specific finding for MAHA. We want to get an LDH, right, which will be elevated in hemolysis because it's released from red blood cells. We're going to see an elevated indirect bilirubin, so we better order that, right? We better order bilirubin because that's going to get released from the red blood cells. We're going to get haptoglobin. That's going to be low, right? So we should order haptoglobin. That's because heme that gets released from the red blood cells is going to bind to haptoglobin, and that whole amount of that complex is going to end up decreasing the free amount of haptoglobin. And then we should usually get a reticulocyte count as well, too. We would expect the reticulocyte count to be elevated, right? Because it's not a marrow problem, it's a peripheral problem. The marrow should be responding. I think you could also add in, it would be feasible to order a Coombs test, right? We didn't talk about Coombs test that much. Coombs test should be negative if you want to just like confirm that this isn't an autoimmune hemolytic anemia. All right. So in summary, right, we've talked about a lot of this. I think I'll let you just like pause your screen and look. But really, we talked about this was everything I just talked about on the last slide. If you see a patient with anemia plus low platelets plus high LDH, get a peripheral smear, confirm the schistocytes. It's a diagnostic clue. If we're suspecting MAHA, we should suspect TTP. That's one of the most scary ones, and then treat appropriately, right? If I suspect TTP at all, we start plasma exchange. If there's a little bit of clinical suspicion, we should start plasma exchange. Secondary causes, the one we talked about was mechanical valves. There are other causes that I'll talk about later. Mechanical valves are the biggest ones. Again, petechiae, confusion, AKI, fever, right upper quadrant pain. You can all think about MAHA. Clinical action points, MAHA plus thrombocytopenia. So again, we need to rule out TTP first because that's what's going to kill the patient. Along with, I would throw DIC in there too. We don't wait for the labs in TTP. We start plasma exchange and steroids, and then caplacizumab and rituximab can be used. The reason I'm harping on TTP so much is because it's going to be on every single USMLE test. You probably every board exam you take for the rest of your life, especially if you go into internal medicine. It is one of the most do not miss this disease. The mortality rate is like over 90% if we don't treat them. Very scary disease. So again, just to put them all together. So TTP is an ADAM TS13 deficiency. We can see neuro symptoms, normal PT, PTT. We do emergency plasma exchange, HUS, bloody diarrhea, AKI. We're going to avoid antibiotics. Atypical is due to complement dysregulation. We can use this nice new C5 inhibitor, eclecizumab, for treatment. DIC, we'll see the prolonged PT, PTT, low fibrinogen, high D-dimer. It's often triggered by sepsis, trauma, pancreatitis, obstructive, malignancy. Remember the malignancy I talked about in another case too, APML. APML is the classic malignancy linked. HELP syndrome, think about a pregnant patient, especially third trimester, right upper quadrant pain, elevated AST, ALT, thrombocytopenia, and malignant hypertension, very high blood pressure, retinal or CNS signs, and we treat it with controlling their blood pressure low. So I covered really everything you would probably ever need to know for USMLE step 1, step 2 for sure, probably a lot of the step 3 stuff too for MAHAs. I did it in under an hour too, right? So that's pretty good. So if you have questions, please email me. Please let me know what other topics you want me to cover. I'm here to help you guys, so let me know.